Welcome, everyone. Thank you for joining us today. We're going to go ahead and get started with our next session, which would be Advances in Treating PNH. Thank you for joining us. My name is Lee Clark. I'm Director of Patient Services. And I'd like at this time to thank our corporate sponsors, our diamond level sponsors, Alexion and Novartis, and our gold level sponsors, Apellis and Genentech. And I'd also like to thank the patients, families, and caregivers who donate and support our foundation. Without everyone's support, these programs would not be possible. We are live today, so welcome to everybody that's joining us through Zoom. We will have a question and answer session after the presentation. So if you're in the room, if you could wait until we give you the microphone, we want to make sure that the questions are captured and everyone can hear the questions being asked. If you're online, please use the Q&A button to submit your questions. We'll go in between questions in the room and questions that are being submitted online. When asking questions, I do ask that you do two things. One, if you're online, submit your question all at the same time to make sure I capture exactly what it is that you're asking. And second, for everyone, please don't share private health information in your question. Our expert cannot answer any specific questions related to your personal health care. We're thrilled today to have Dr. Jamile Shammo, who will be presenting today on PNH. Dr. Shammo is the director of the Bone Marrow Failure Program and a professor of medicine at Northwestern University, Feinberg School of Medicine here in Chicago. Dr. Shammo has been a longstanding friend of the foundation and always helping us out. We know she has a passion for educating patients. She's very involved in research. Without her expertise, a lot of the treatments that are now available today for patients would not be possible. Dr. Shammo is world recognized as an expert in the field of PNH, and we are so delighted that she was able to spend her Saturday with us. Welcome, Dr. Shammo. Thank you for coming to join us today.
Thank you so much for this kind introduction, and I like to ask the organizers, also the AAMDS, for inviting me today to talk to you about PNH, a disease and patients that are very dear to my heart because of my career spanned pre-PNH directed therapies and post-PNH directed therapy. And I was able to see firsthand the tremendous impact on patients' quality of life and longevity, for that matter, with active therapy. It never ceased to amaze me how, historically speaking, all the discoveries that came into the field of MDS from the very first identified PNH case in 1882 by Strubing, who remarkably recognized that the hemolysis that happens in PNH happens intravascularly, that is inside the vessels. And when you think about what kind of laboratory tools they had at that time, and he reasoned that that was some destruction of red cells that took place for a reason, but that reason was not yet identified. And slowly but surely, the story of how PNH and why PNH develops became sort of started to get unfolded. So Ham, for example, identified a test whereby we can sort of test for PNH cells, which was something we learned in med school, but is no longer in utilization because of its complexity, and we have better tests right now. Later, a major discovery was the alternate complement pathway, because those cells were lysed in a way that's independent from having an antibody, which was what was thought how complement acted. But here you didn't have any antibody. So exactly how did the destruction happen? Well, Pilomir identified the alternate complement pathway, which I will be talking about in a moment. Some of the more interesting observations came later, in that PNH cells are so resilient, and they somehow maintain their presence in the setting of bone marrow failure. So how do they not get destroyed like other hematopoietic stem cells? And so some scientists reasoned that they must have some survival advantage that keeps them going, even though all the other hematopoietic stem cells die. Later on, at Duke, Ross identified that those cells tend to be exquisitely sensitive to complement destruction, and they tend to have a lot of C3 deposits on top of those cells. So that was an important discovery. But the clonal nature of PNH did not happen until work by Luzzatto, who utilized G6PD isotyping, showing that in this, what we thought to be a benign disorder, i.e. not malignant, we have clones that originate from the same cell. Well, in a way, PNH spans clonality as well as hemolytic anemia in the setting of some bone marrow failure. In the 80s, the identification of CD55 deficiency was followed by CD59 deficiency as two factors that were critical for shielding the cells from complement destruction. And so when you don't have those cells, those receptors rather on the cells are likely to be lysed. But it wasn't until 1993 when the reason for this loss of those receptors was identified by Kinoshita, who showed that actually you have a mutation in a particular gene that leads to inability to form an anchor, which I will show in a moment, that leads to increased susceptibility to complement lysis. I don't know. Maybe we can have next slide, please. Thank you. One thing that you could see in the books, and we try to tell house staff, that this combination of hemolytic anemia, propensity for developing clots, and bone marrow failure can be identified in most people who have PNH, but there's a great deal of spectrum that can apply to many patients you see. So sometimes they might present with hemolysis without the other two features and vice versa. So this is perhaps the more pure form of this entity, but certainly you really don't have to have all three elements to make a diagnosis. So the etiology, as I've already alluded to it, you see that little structure? Let's see if I can point to it. I guess not. So there's a little structure that protrudes from the cell membrane. The mutation causes the cells to not have that structure, and that structure carries on it a bunch of proteins included in that CD55 and 59. So when you don't have those proteins, the cells are very susceptible to complement lysis. This is an acquired mutation in a gene that's on chromosome X. This is not hereditary. A lot of patients ask me, well, okay, so if this is a mutation in a gene, will I be giving this to my family members? And the answer is no. That isn't how it happens. How exactly it happens is another point of discussion, but it's very possible that the cells that are being destroyed in the bone marrow, in the setting of bone marrow failure, acquire this mutation so they can evade destruction by T cells, which is part of the immune system. But unfortunately, now they get recognized by the complement and you develop hemolytic anemia. One important piece that those cells, the clones, essentially do not necessarily proliferate like malignancy would, but they expand essentially. And so disease manifestation requires clonal expansion. I'm sure many of you have seen the complement cascade. And I will try to kind of gear this towards our understanding to how we treat this disease right now and what might be coming in the future. So remember that there are 3 different ways in which you can activate the complement, which, by the way, is the oldest part of our immune system that doesn't require any education, meaning it's there to protect us as an organism in the setting of a world that has a ton of bacteria and fungi. So the complement, if any of its protein sees a non-self, it's going to activate. first time, second time, third. There's no, it's a knee-jerk reflex. So a non-self molecule will get destroyed all the time whenever the complement activates. So classical pathway happens when you get antibody, like in people who have autoimmune disorders, you get complement activation and cellular destruction and its consequences. Lectin pathways when you encounter bacteria, and then complement gets activated and the body gets rid of the bacteria. The alternate pathway presumably is the oldest, or at least in theory, branch of the complement system that is in existence. Why? Because it's constantly on. It's turned on all the time. It doesn't require an antibody. It doesn't require a bacteria, but it's constantly in a state of agitation to produce what causes the complement to be constantly on. So if it encounters a non-self in the form of bacteria, fungus, or what have you, it will destroy it. And how it happens is that it's sort of like a domino effect. You get the initial reaction, and then the domino effects follows. Once you get to the terminal complex arm, which is when C5 dissociates to C5a and C5b, there is no stopping. It keeps going until you form something called membrane attack complex, and that causes the formation of holes in any cell it encounters, and that's how you achieve death of that specific cell. To the bottom right is actually an electron microscopy photograph of a red cell. That's the end result of membrane attack complex and complement activation. If this happens inside the vessels, which is likely to be the case, it's called intravascular hemolysis, or IVH. So you can see a depiction of what that looks like on a naked red cell that doesn't have CD55 and 59, and consequences, all that free hemoglobin inside the vessels. To the left, you see a red cell that has C3 deposits. This is what Dr. Ross described in patients who have PNH. And this phenomenon is not really that much recognizable in newly diagnosed patients. Why? Because every C3 coated cell is going to ultimately be destroyed by the formation of C5b29 or membrane attack complex. However, this is relevant when we start talking about C5 blockade. So if you block C5, now, yes, you prevented IVH, but all those cells will remain coated with C3 deposits, C3 fragments, and then they get picked up in the liver and spleen. And that is what's coined as extravascular hemolysis. So the destruction of those cells doesn't happen within the vessels. It happens in the liver and spleen, in the reticuloendothelial cells right now. And so when you block C5, the number of those cells increases and you get manifest EVH. So that's the second type of hemolysis you should be thinking about. Granted, in the alternate pathway, there's a whole lot more that we know about molecules that lead to the activation of the alternate pathway, and it's actually part of how some of the new anti-PNH therapies are being developed. But if there's anything I learned about PNH, and that's really relevant to patients, is that it's a spectrum of disorders. On one end, you have bone marrow failure, whereby the clinical presentation is more of neutropenia, a low platelet count, propensity for infection, someone needing transfusions. And on the other end, as you see in blue, is classic hemolytic PNH. So the patients could be anywhere in between. And sometimes it's important to understand actually where the patient is so that you can think of the appropriate therapy. So if I have someone who has a very small PNH clone size, so here is where size matters actually in this disorder. Smaller PNH clones, less than 10%, some people say less than 1% is very common in aplastic anemia, as I'm sure you've heard. Those patients require different treatment, and anti-complement therapy may not be as effective. On the other end, when you have larger clone size, features of hemolysis and organ damage, granted, that's the patient that requires PNH-directed therapy. And there are patients who sit in the middle And those patients are very difficult to characterize because one feature may override the other, and it's typically directed by certain characteristics for each individual patient. So remember that. Let's talk a little bit about available therapies. It's so wonderful for me as someone who takes care of PNH patients to see that we have a plethora of available drugs. It started out in 2007 when C5 blocker, eculizumab, became approved. Then it took maybe 11 years to develop the next C5 blocker, ravulizumab. Crovalimab is another C5 blocker that was developed and approved recently. And then we have C3 blocker, pegcetacoplan, which targets the complement at a higher level. And any complement inhibitor that targets the complement at a higher level than C5, in theory, could block both intravascular and extravascular hemolysis, because now you don't have to generate those C3A and B molecules to coat your red cell because you're already blocking C3. And then there are two other oral inhibitors of the alternate pathway. One is factor B inhibitor, or iptacopan, which was approved in December of last year. And just in June, we received another approval for danicopan, a factor D inhibitor. And again, both are given as tablets, one as monotherapy in iptacopan and the other in combination with C5 blockers. So it's actually a remarkable, when I showed you the historical timelines from the very first time the disease was described to the point where we have 5 different active agents, is, to me, rather remarkable, and more on the way, by the way. I think it's very important to talk about the very first monoclonal antibody that was developed to block C5. If you block C5, you're blocking the formation of membrane attack complex and inhibiting this type of cellular destruction. So this was engineered in a very interesting fashion. So the two parts are known as the variable region. So that's the region that binds to whichever molecule it's targeting, in this case, C5. And then the bottom part is the part that actually gets picked up by the lysozyme or endothelial or reticuloendothelial cells, and whatever it's carrying gets destroyed, essentially. So this is the backbone of ravulizumab also. So, but this is how eculizumab was constructed. And in the very first randomized clinical trial, this is the TRIUMPH, which randomized patients to active drug or standard of care, which was transfusion, supportive care, or what have you. And I just wanted to show you, just so that you can see the kind of patients that were enrolled onto this clinical trial. You can see their age in the 30s, 41 in each arm. Look at the duration of PNH that they had. This was the very first active drug that we had. Some lived with it for 10 years. Some, if you can see the range, up to 38, 29 years without any active therapy. It's remarkable. Some had history of aplastic anemia. Some had MDS. And 20% of those people had clotting events. So 1 out of 5 patients that were enrolled on the TRIUMPH study had clotting events. And a lot of those people were treated with anticoagulation. They were treated with steroids because we had really nothing else to give. And certainly all of those patients, by the way, that were enrolled had transfusion needs, okay? So the primary endpoint was to see how many patients came off transfusion. So from the get-go, you could see to the top part how the LDH precipitously dropped in the first week or two. And that actually mirrors the clinical experience. You get the drug, you expect the LDH to drop significantly, whereas the placebo patients didn't. They just went on. Importantly, you know that active treatment of PNH salvages red cells. And that's a concept that I always tell patients. You need to realize that when you're salvaging the diseased red cells, their number is likely to increase. So the red cell size goes up, not down. And that's always an issue that people have difficulty grasping. How could you increase the disease? Well, because you're protecting them from lysis, but they remain abnormal. So this is the reduction in transfusion that happens with eculizumab in purple and in blue. It's actually, let's see, the median, the purple is placebo and the eculizumab is in blue. So you can see the significant reduction in transfusion that took place. But if you had someone who had more than 25 units of blood administered in a year, you can imagine their transfusion requirement isn't going to be abolished entirely, right? So, but for the most part, you could say half of those people became transfusion independent. And moreover, because of the fact that this drug has been around for over a decade, we have some data on survival. And pertinent to all of you who have this disease, it's heartening and wonderful to see that the survival curve for patients who have PNH is almost superimposable to those who are age and sex matched in the general population. So these types of data require long-term follow-up and is very important for patients to see compared to what you have on the left, which is what it was the case prior to having active therapy. Now, ravulizumab is it's a fascinating way of thinking about how to reutilize the same antibody over and over and over by some genetic manipulation to the antibody, to the monoclonal antibody that captures C5. So if you change a few amino acids in there, suddenly the drug, the C5 molecule rather, can dissociate from the antibody and it can go out into the circulation and keep going, which is why the half-life of this drug is 4 times that of eculizumab. And I'm probably not telling you anything you don't know. But this is why the drug can be given every 8 weeks instead of every 2 weeks, precisely because of its affinity to certain receptors and bioavailability, despite being in the endozyme. So furthermore, what seems to be the case in ravulizumab is that there is, I can't say the word better, but I can say maybe more efficient blockade of C5, because the top graph shows you the level of free C5. And if you know, this drug is a C5 blocker, correct? So if you have free C5, that means above a certain level, that means that you have not achieved a perfect blockade of this molecule. And the top one you see, this is ravulizumab, and it's completely below the required 0.5 level, telling you that there's persistent, ongoing blockade of C5 at all times. Whereas the bottom one is eculizumab, and you can see that there's some degree of fluctuation, right? So sometimes maybe you're risking having a little bit more free drug and perhaps breakthrough hemolysis. This drug was compared to eculizumab in 2 trials. One is the 301 trial for treatment-naive patients, comparing those who have PNH between eculizumab and ravulizumab. And the other study was the switch trial. Those who were on eculizumab and had perfect control of their disease were also randomized to ecu versus ravu. And the idea was to see how does ravulizumab fare with the standard of care at that time. And they were called non-inferiority, meaning are they equivalent in efficacy to the drug that we already had. So in each and every, whether it's a co-primary endpoint or secondary endpoint, et cetera, the drug, new drug ravulizumab was not inferior to eculizumab. And based on those trials, the drug was approved. Now, the investigators couldn't help themselves, even though these were equivalence trials. They noted that the breakthrough events were certainly so much lower in patients who were randomized to ravulizumab, such that nobody had breakthrough hemolysis with free C5 that was above where you wanted it to be in both switch or the treatment naive. But I think it's very important to recognize that even in the best hands, when you have eculizumab that or I should say ravulizumab, that has amazing control of C5, life happens and infections happen. So if you have infections, which is labeled as pharmacodynamic breakthrough events, meaning that someone had, I don't know, urinary tract infection, someone had COVID, for example, someone had pneumonia or what have you. In that case, you have so much complement activation that overwhelms the complement, or actually the amount of free drug that you have on board. And so you get what we call breakthrough hemolysis. So it's not a matter of the drug not inhibiting C5. It's the fact that you have much more C5 generation due to, let's say, classical complement activation when this is infection related, et cetera. So it's a very important point to remember that breakthrough events, meaning elevated LDH, drop in the hemoglobin, accompanied by, let's say, hemoglobinuria or what have you, and that's the classical definition for it, can happen. And education, knowing when is it that you can pick up the phone and reach out to your doctor if you developed an infection is extremely important. In the 302 study, which is the switch trial, there was a sub-study that asked patients, and I brought this only because I know patients are my people are listening. So there were reasons why the majority of those patients that were enrolled on that switch trial favored ravulizumab, and you can see the top 3 choices because now you have 8 weeks between your infusions. You can go have a vacation or be slightly free from this infusion center. Although in some instances you can get this administered at home. Also being able to have activities, improvement in the quality of life. Granted, this was, I mean, not surprising, right? That's what I thought I saw with my patients. But what about long-term? We always say that long-term data are so important. Great, you know that a drug is effective, yes, but I think you need to know long-term safety, toxicity, durability of this response. And it appears that you have, through 2 years of treatment, sustainability of the response. So transfusion avoidance, you can see it's not 100%, right? So like I told you in the very first part, it's 70 to 80%. There's always going to be a subset of patients that will require additional workup to understand exactly why. And these are also graphs showing durability of LDH in both clinical trials. So you have constant control of what we know as intravascular hemolysis. We need to be very cognizant of adverse events. And these are, again, long-term follow-up of both trials. And you can see that fewer events were thought to be related to the drug and led to study discontinuation at the very bottom. Some patients actually developed vascular events, thrombosis, et cetera. But for the most part, it didn't look much different from what the toxicity profile or the safety profile of that of eculizumab. So there's some comfort in knowing that, with the exception of what we talked about, the drug seems to be relatively well tolerated. And now we have 4-year follow-up, and that too seems to be similar from a survival standpoint to eculizumab. What about crovalimab? So what's the difference? Why exactly did people develop another C5 blocker? Well, crovalimab, yes, it's a C5 blocker, a monoclonal antibody, but it binds to a different epitope of C5. And for a while, few patients, very few patients were described that didn't respond favorably to either ecu or ravulizumab because they have polymorphism in their C5 genes. So essentially, the binding site of either eculizumab or ravulizumab did not conform to the molecule because they had various sequence to their amino acids because of the mutation. This drug binds at a different site, so even those patients who have resistance to either ecu or ravu will respond. And this was also evaluated in 3 separate trials, Commodore 1, 2, and 3, again, comparing it to eculizumab and demonstrating that actually you have significant reduction I would say it's very similar. The profile of this agent to any C5 blocker is extremely similar. And this was Commodore 3, which was a single-arm study in crovalimab in treatment-naive. Now, one interesting piece about treatment-naive patients being treated, we cannot do placebo trials anymore in this country because it would be unethical, right? To say we're going to randomize you to best supportive care when you know that there's an active agent that works for this population. So those trials, when you're looking at single arm, looking at a new drug randomized to supportive care, is done in countries when they have no access to treatment, which is kind of sad when I think about it, that there still is a need for having access to those drugs worldwide, if you will. Obviously, when you are treated with a complement blocker, meaning, which is responsible for clearing bacteria, and for the most part, meningococcal and encapsulated organisms, so meningococcal infections are a reality. And I can't overstress that to my patients who are started on treatment. Everybody should have their card. They should become familiar with symptoms and signs, and don't blow them off, because those infections and complement activation can happen. And that's not meant to be anxiety provoking. It's actually meant to help patients understand what they are up against and to become familiar with when to call the provider. So fever, headache, vision changes, any unusual rashes must be reported right away. And that card, you shouldn't be the only one carrying it. I would give a copy to one of your family members, because I think they need to know as well what to monitor for. And because of those reasons, it's important to have this given through what we call risk evaluation and mitigation strategy, whereby your physician needs to know what are some of the risk and adverse events and educate you on that. So over time, it became clear that patients who are being treated with C5 blockers are having various hematological responses. So some people may have a perfectly, completely normal hemoglobin. As you see here to the right, 11% had this complete response, whereby they have completely normal hemoglobin above 12 grams. And at the very bottom, patients who continue to require transfusions and have hemoglobin below 8 grams. You see, so it's a spectrum of responses to C5 blockade. And this is sort of real world data. Here, we're not talking about the clinical trial. We're talking about what happened in real life when you took this drug and applied and gave it to patients. And in the LEADS group also, and in the UK, it's different than the United States, where they actually have 2 centers that look at patients who have PNH, and then they tell the patients whether or not they are eligible to receive this treatment. So they have a massive number of data, and here you have close to 500 patients, and you see the bottom part saying that about 27% require transfusions despite therapy. So that's what got all the PNH docs into a thinking mode. Okay, why is it that some of those patients require transfusion despite active therapy for this disease? So it was also noted that a subset of those patients have a higher than the recommended dose. Everybody knows that eculizumab is 900 every 2 weeks, but 20% were getting up to 2,400 milligrams, which is a much higher dose than we normally do. And so that became sort of an interesting exercise for physicians who take care of PNH patients. And I can't overemphasize the fact that causes of residual anemia, so if you happen to be a patient who has anemia despite active therapy, it's important to conduct a diagnostic workup. I mean, it's not a rocket science, right? Someone has anemia. We should not be automatically saying this is the reason, extravascular hemolysis is the only reason. It isn't. I can tell you from my practice, I've seen a lot of patients who have folate deficiency, people who have iron deficiency for some other reason, GI blood losses, etc. I've seen patients who have chronic kidney disease, and hence they have anemia because their kidneys are not exactly perfect, right? And so it's very important for the physician to monitor and understand why someone is anemic. Rule out every possible cause for anemia, rule out every possible cause for bleeding, GI losses, and then do a diagnostic workup to make sure that this patient that has been on C5 therapy hasn't developed what we know as extravascular hemolysis due to C3 coating on the red cells and pick up in the spleen and liver. And a few words about that, like a lot of times people say, well, how do we detect those C3 cells, C3 coated cells? Well, in the trials that evaluated that, they did something called flow cytometry. So flow cytometry is the very, very sensitive method of detecting those C3 fragments on red cells. In reality, I don't do that in clinical practice, but what I have access to is something called Coombs test. And in general, PNH is Coombs negative at diagnosis. But if it turned positive, and now you have elevated reticulocytes telling you that the bone marrow is on overdrive, this isn't bone marrow failure, right? You have enough regeneration, but now your cells are getting picked up in the spleen. That would be your extravascular hemolysis. So essentially, this is the depiction of what EVH is. And what should we be doing about this? Well, first of all, you have to decide, is this clinically significant? Is your patient requiring transfusions? If yes, then I think that's clinically significant. We don't want a patient to suffer from having transfusions every so often. And then you have to come up with a plan. So now you can offer other complement inhibitors like pegcetacoplan, iptacopan, or danicopan add-on therapy to C5 inhibitor. All three are FDA approved or consider clinical trials. And may I ask how many would consider participating in clinical trials today? Like, let's say you had extravascular hemolysis. Can I have a show of hands that of patients who might actually be interested in clinical trials? Okay, well, that may be something we can talk about in the breakout. And this is actually what led to the development of other drugs that are higher up in the complement cascade. So pegcetacoplan is one such drug given sub-Q twice a day. And this is the Pegasus trial, the pivotal study that led to its approval. So it took patients that happen to have a hemoglobin below 10.5 or those who require transfusions and randomized them after a run-in period to either pegcetacoplan or they remained on ECU until they looked at the primary endpoint. And in this case, it was change in hemoglobin from baseline. And then after that, everybody could channel into an open label pegcetacoplan. So this graph speaks volume, yes? So you can see the hemoglobin at the starting point, a little over 8 grams for patients who were on both eculizumab at baseline. And then essentially the remarkable separation in curve that happens when you added pegcetacoplan. Of course, you do it for the first 4 weeks, and then you continue without eculizumab. So there's a significant improvement in hemoglobin after exposure to a C3 blockade, further verifying the fact that, look, those patients' anemia and transfusion dependency were actually related to extravascular hemolysis. But again, this is in people who have failed eculizumab or developed anemia while on ECU. If you looked at the safety profile, that's very important. And again, the two seem to be rather comparable. But importantly, you need to look at hemolysis. So the hemolysis in the initial phase, the fourth from top, was seen to be a little bit higher in the eculizumab arm. But after switching, when everybody switched to pegcetacoplan, it's about 20%. So 1 in 5 is expected to have a hemolytic episode while on this drug. And many of you might know or may have experienced, the fact that the dose could be escalated because it may very well be a matter of pharmacokinetic, meaning the availability of this drug in the system, and it's given 2 times a week, so the drug could certainly be dose escalated to a higher dose for better control of hemolysis. And again, I've dealt with several instances as such with reasonable responses. And so this basically is the frontline trial that was conducted with pegcetacoplan in treatment naive. Here, you don't have to do any run-in or anything. You can just simply give the drug. And you can see the difference between standard of care and pegcetacoplan relative to hemoglobin improvement. So further confirming the activity of this agent in treatment naive. Now getting onto the novel agents that were just approved. So iptacopan is a factor B inhibitor. Now factor B gets cleaved by factor D to form what we call a C3 convertases, which ultimately cleave C5. So if you blocked factor B, it's the same story, just like C3. Now you can overcome both intra and extravascular hemolysis. And this is a tablet that you can actually take 1 tablet twice daily. So here is what happens in the switch trial. So this is the apply PNH. So there were 2 clinical trials. This is the apply that took patients that have already received eculizumab and had hemoglobin below 10 grams or were transfusion dependent. And then they were randomized to either iptacopan or maintained eculizumab. And after 24 weeks, they were offered iptacopan for all patients. And again, you can see the mean hemoglobin level going from 8 point something to over 12. Remarkable. And this was a late-breaking abstract at ASH a couple of years ago because of the magnitude of hemoglobin improvement when those patients were treated accordingly. And in the same thing, here you can see the fact that assessment of transfusion avoidance continued. So if you looked at the very right, from week 26 to week 48, when everybody was receiving iptacopan, you can see that 94% of those people were not requiring any transfusions, right? So that is remarkable. And if you told me, I don't know, 20 years ago that we would be having a tablet that could control PNH to this magnitude, I would not have believed it. But evidently we have this remarkable development in this situation. Obviously, treatment-naive patients were also studied, and this is a single arm. So this is somewhat different in that it didn't look at treatment-naive patients comparing iptacopan to, let's say, ravulizumab. This is just a single-arm study looking at oral iptacopan in people who had PNH with low hemoglobin, evidence of hemolysis, and again looked at responses relative to hemoglobin and how high of a hemoglobin do you have and do you require transfusion. And here again, duplication of the remarkable results in that the primary endpoint being increase in hemoglobin of at least 2 grams in the absence of transfusion, the majority of patients, and people reaching above 12 grams, normal hemoglobin, in about 60%. But again, not 100% and not randomized to active therapy. In this case, would be ravulizumab, but again, further confirming the activity of this agent. If you collated all patients, you can see the hemoglobin level by week 24, which is rather remarkable. You can see the improvement happening in the first couple of weeks, which is again is tremendous. Here's the LDH normalization in the first couple of weeks. Here you can see the quality of life, which is so important for patients who are being treated. Again, a tremendous, significant improvement. And most of the patients reported mild TAEs. There were no deaths, and hemolysis was observed, but not necessarily serious. But again, remember, long-term follow-up is extremely important in these trials. And we don't have long-term follow-up. I know people say 48 weeks. 48 weeks is almost a year. right? So when you think about long-term follow-up, that may matter to you or may be defined by you a little bit differently than what I would think as long-term follow-up may be. Moving on to the last agent that was just approved in June, this is danicopan, a factor D inhibitor. So this actually blocks factor D, which is responsible for cleaving B, okay? And that is the drug that is also oral, is given 3 times a day on top of a C5 blocker. And this was the abstract that was submitted at EHA, was presented actually in this past June. And there's an update, and the manuscript actually is in preparation. So how did this study go? Well, you have patients who had hemoglobin below 9.5 and or require transfusions, have been at least on 6 months of Ravi or ECU and continue to experience anemia or transfusion dependency and receive the drug orally 3 times a day. And after looking at the primary endpoint, which is essentially hemoglobin improvement, then everybody channeled into the tablets essentially to see how they fare after switching, and then a very similar study design to the apply with iptacopan. So the patient characteristics you can see here, many patients had been on C5 therapy for 5 years minimum at the very bottom. And I would say half and half, most perhaps received eculizumab, and you can see the need for transfusion, et cetera. And here's the graph showing you the difference between C5 blockers and danicopan. And you can see how there's, again, significant improvement in hemoglobin with the add-on drug. And then when everybody was offered the switching from placebo in green to danicopan, their hemoglobin also rose at week 12, further confirming that this is actually an active drug. It controls extravascular hemolysis, and based on that, the drug was approved. This shows you the drop in the reticulocyte count that happened when patients received active therapy. Controlling reticulocyte count is important when you're talking about extravascular hemolysis because your red cells are being turned over. So controlling that means that you've controlled this process. And so again, when it comes to transfusion avoidance, you can see how much better it was in patients who had received danicopan, either from the get-go or ultimately when they switched. And then the side effects, and again, life happens, so you will, if you happen to be one person who was interested in danicopan as add-on for EVH improvement or transfusion avoidance, breakthrough hemolysis can still happen, so we need to monitor this moving forward. And liver function tests have to be also monitored because of reported events with hepatobiliary disorders, et cetera. No deaths or meningococcal infection, but again, follow-up is rather short. So a few words about proximal complement blockers is that while they improve the hemoglobin, they're also increasing the abnormal red cell clone. So if breakthrough hemolysis happened, in theory, it could be more severe than what you've encountered otherwise. And remember that while oral drugs are amazing developments, compliance or people forgetting, like when I say compliance or lack of it, it's not intended to make patients feel guilty, but we're all human, we forget. But these are extremely important, and you must remember to take your medications as prescribed, otherwise you're risking breakthrough hemolysis. And the last but not least, which is important, is that those new agents have never been compared head-to-head. We don't have data comparing iptacopan to danicopan to pegcetacoplan. So it's difficult to make the comparisons. And I think for each patient, it's a discussion on what is important for them. And the patient input is extremely important. And finally, again, it's embarrassment of riches, right? We have so many new drugs that may be coming down the pipeline. There are drugs that are being evaluated that are upstream from even factor D. They're MASP inhibitors, for example. There are biosimilars that are being developed and are utilized actually. So in each and every part of the complement system, there are drugs that are being considered. So I think it's remarkable to see all that comes out from the basic lab to patients, but we still have few dilemmas that we haven't resolved yet. Time to initiating treatment of PNH-directed therapy is always an issue. What do we do with residual anemia and how do we tackle EVH best, given all the drugs that we have? Increased risk of not just meningococcal infection, but other infections, something we need to monitor long term. And finally, unfortunately, it's not very common, but we continue to monitor for evolution of PNH patients to either aplastic anemia or other forms of myeloid disorders. So that's the last slide. Thank you for listening, and we have a few minutes for questions.
Thank you, Dr. Shammo. Do we have any questions in the room? Start.
Good, I've sold them all on.
Yeah. Okay. Well, we'll see if we have. In 1 minute, we're looking here. We have a question for Dr. Shammo, and the question is: when switching, are there anything patients should be aware of if you happen to be switching from one treatment to another? And is that switching based upon the two drugs you're switching?
That's such a good question. It's actually a practical application to what we already have. So I generally like to say that we follow the clinical trial that evaluated that drug. For example, if you're switching from, let's say, eculizumab or ravulizumab to pegcetacoplan, so there was a run-in period, right? Because the PK, the bioavailability of the agent requires a few weeks of therapy before you reach a steady level. So you need to have a run-in period. For the oral agents, if you're doing an add-on to treatment, as would be the case in danicopan, I think you simply add on the drug to whatever treatment you have. Iptacopan, there isn't actually any, I should say, guidelines on what to do, but it's, if you have someone who, let's say, is on eculizumab, it's probably a good idea, and I know that these are expert guidelines and recommendations. You should do this in the very first couple of weeks, perhaps better in the first week of exposure to a C5 inhibitor to switch to iptacopan. Iptacopan has much better bioavailability than in terms of hours. So the ability to inhibit the target is faster. So you should be able to switch this in the first week after receipt of eculizumab or the first 4 weeks of receiving ravulizumab and move on with the oral therapy. So it's better to do this while you still have some drug on board. I hope that answers the question.
Yes, thank you. Any questions from the room? Okay. Next question online is, Dr. Shammo, do you still feel that it takes a long time for a patient to get diagnosed with PNH?
That's another good question. I think there's been so much, the spotlight has been on this disease as it deserves for some time now, since we have C5 blockers, et cetera. So I think the time to making that diagnosis has improved tremendously. I did a paper together with AAMDS Foundation a few years back, and we sent a survey to all the patients asking how long did it take for them to get diagnosed. And it was, most patients were captured within 5 years, and certainly in the first 2 years of seeking medical attention. That's very different from what we had, a couple of decades ago when it was 10 years time to diagnosis, and in part, not only the awareness of the disease, also because having a better test, a flow cytometry of the peripheral blood will give you the answer. I see no reason why patients who have a higher likelihood or possibility of having PNH being diagnosed accurately and expeditiously. The problem is, I think, in my opinion, is the next step. Now, what do we do with those patients that we have diagnosed? That, I think, is a problem, because you may end up with patients who have smaller clones, larger clones. Maybe we have this next generation sequencing. You're finding that you have other mutations. What does that mean for the patient? So that's the second part. And the third piece that I think we have problems with is, how do you characterize the residual anemia that those patients have? No longer are we just satisfied to say, oh, we've controlled intravascular hemolysis. I think we need to further characterize anemia or cytopenias, for that matter, a little bit better. So the long way to answer the question is that, yes, we're making a diagnosis faster, but we need a lot more yet to optimize the care of patients who have this entity.
Any questions in the room? Okay, we'll go to another question. Oh, I'll do a question online and come right back. Our next question online is, I was diagnosed with PNH, but for many years before, my blood counts were low and I always felt fatigued. Is it possible that I had aplastic anemia, but then was diagnosed with PNH? And does that really matter?
I think, okay, so it's really tough to say without knowing the full story and what the blood counts look like. Aplastic anemia doesn't usually recover by itself, so it'd be hard for me to believe that someone had aplastic anemia, recovered spontaneously, only to develop PNH. It's probably one of those overlap syndromes. But to diagnose aplastic anemia, a bone marrow biopsy needs to be performed to look at how many cells you have in there, cellularity we call it, and to look at the degree of cytopenias. In general, it's not just the anemia, it's also neutrophil count and platelet count that we look at. And those numbers have to be low enough in conjunction with the bone marrow to make that kind of a diagnosis. But PNH can be found in what maybe majority of patients with aplastic anemia, albeit at a very low level. So you're right in that PNH clones expand over time, and then they probably show clinical relevance in terms of hemolysis and anemia and fatigue, of course, as you're experiencing. But and it's not uncommon to happen, but I can't say for sure that aplastic anemia could spontaneously recover and PNH clones manifest.
Dr. Shammo, toward the end, you showed a slide with all the wonderful novel agents. I saw that some of them were blocking like significantly upstream pathways, more and more upstream. So depending on the infection type, is there a worry that the complement amplifying condition might bypass the inhibition
of C5 or upstream? I mean, I think, Narman, you know that this is work in progress, right? And that's why we do clinical trials. I worry, and my worry could essentially be maybe not founded, but when you're blocking effectively the complement system, infection is what we have to monitor for. So we have some data with eculizumab over years, right? And we can say, hey, you know, here's what you might expect. But with all the novel agents and the higher you go, I think that's why it's essential to continue to look at the long-term follow-up. And not just infection. What about other complications? What about emergence of autoimmune conditions? I mean, there's all kinds of unusual side effects that could happen when you're blocking the complements, or perhaps interaction with some other proteins. But I can say that in theory, it's attractive to explore other agents, because that's how we learn about this process, perhaps in the future. But I tend to agree that we have to do it. We have to do it with open eyes.
Okay. Well, thank you so much, Dr. Shammo, for sharing your time and your expertise with all of us today. This session was recorded and it will be available on our website within 7 to 10 business days. If you have any additional questions, you can send it to us at any time in 3 ways. Send an email to help@aamds.org. Give us a call at 800-747-2820, or you can always submit your question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us today, making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 41 years. This concludes our program. Thank you so much,
Thank you.
Dr. Shammo.
Thank you.